Good morning, everyone. We are Group 3, and the title of our research is Filling Little Bodies, A Parent's Guide to a Kid's Nutrition, focusing on combating childhood obesity. We want to begin by asking a simple question. What does childhood wellness look like to you? Is it just being free from disease, or is it something more? Well, for us, it means a child with energy, confidence, and the opportunity to grow into a healthy adult. But unfortunately, that vision is at risk. Today, we're tackling a challenge that's become a nationwide epidemic, childhood obesity. As we know, obesity is a complex disease made up of genetic, socioeconomic, environmental, and physiologic factors, and it has now become the most common chronic disease amongst the pediatric population. Through our community-based intervention at Roosevelt Elementary in the city of Linwood, we wanted to explore how targeted education and culturally sensitive outreach can empower both kids and families to take control of their health, and how we, as future providers, can be part of that solution. Childhood obesity is not just a health issue. It's a crisis that threatens the well-being of an entire generation. According to the CDC, nearly 14.7 million youths ages 2 to 19 years old have obesity in the United States. That's about 1 in 5 children and adolescents. And the rates are even higher among certain racial and ethnic groups. These children are at increased risk for chronic conditions like type 2 diabetes, asthma, and hypertension, and many experience psychological effects such as low self-esteem, anxiety, and social isolation. Even more concerning, national data shows that both obesity and severe obesity rates have risen steadily in the youth over the past decade. The problem is clear. Without early, culturally responsive, and family-centered strategies, we risk letting childhood obesity shape the future health of our communities. Our project aimed to be part of that change, one child, one family, and one school at a time.
As we have previously mentioned, childhood obesity is a multifactorial disease caused by a complex interplay of factors, including race and ethnicity, showing that childhood obesity is highest in Hispanic and non-Hispanic Black children. Children with high ACS scores have an increased risk of developing childhood obesity. We have also come to understand that childhood obesity is a genetic condition. A lower socioeconomic status promotes food insecurity and reduced opportunities for physical activity, which contributes to childhood obesity. School environments significantly impact childhood obesity through the availability of unhealthy foods, the provision of opportunities from physical activity, and the influence of school policies and practices on students' eating and exercise habits. Finally, limited health education hinders individuals from understanding the importance of healthy eating and physical activity. Some evidence that supports our actions, specifically in the community we were focusing on in Linwood, California, 48.02% of students from 5th to 9th grade are considered obese. This is compared to only 5.9% in the more affluent community of Redondo Beach. Latina and Black children are disproportionately affected, um, and childhood obesity increases the risk of type 2 diabetes, high blood pressure, cholesterol, low self-esteem, and depression. And school-based programs and community-level interventions in high poverty areas lead to better outcomes when multiple approaches are used, such as education, access to healthy food, and safe play spaces.
Now, let's walk through the 2023 American Academy of Pediatrics Clinical Practice Guidelines for the treatment of children and adolescents with obesity. These updated recommendations represent a significant shift in our approach. It's moving towards earlier and more intensive interventions. Every youth with childhood obesity starts with intensive health, behavior, and lifestyle treatment, or IHBLT, which is recognized as the first-line therapy. This treatment should include a minimum of 26 contact hours, that is face-to-face, family-based behavioral counseling over a period of 3 to 12 months. It's delivered by a multidisciplinary team typically including pediatricians, registered dietitians, and behavioral health specialists. This approach emphasizes the critical role of early, coordinated, and structured interventions to modify long-term outcomes. Next, in line, we have pharmacotherapy, and it's recommended for children 12 years and older who have a BMI of greater than the 95th percentile. And this is also indicated if they have not responded adequately to IHBILT. It is not appropriate as a standalone intervention, meaning that the child should continue seeing a behavioral health specialist, and the family must continue working with the dietitian and their pediatrician. Some approved medications include GLP-1 receptor agonists, such as liraglutide, which has shown efficacy in the pediatric population, and it's something that is being used today. Lastly, we have bariatric surgery and it is recommended for adolescents 13 years and older who meet specific clinical criteria. They must have severe obesity defined as a BMI greater than the 120th percentile. They must also have clinically significant comorbidities such as diabetes, prediabetes, hypertension, and a documented failure of IHBLT. These recommendations underscore the importance of early identification and escalation of care when appropriate. These guidelines emphasize that when you delay intervention, it could lead to worsening health trajectories, and they encourage a proactive, evidence-based approach tailored to each of the child's needs. As clinicians, our role is to ensure that these options are accessible, equitable, and integrated into a comprehensive care model. Okay, while these are current clinical guidelines, our intervention today focuses on taking the first step by providing parents with an educational presentation on nutritious foods and appropriate portion sizes based on myplate.gov. This intervention is not intended to replace IHBLT, but rather to start the conversation with families. And our goal is to help parents understand that the first line therapy for childhood obesity centers around lifestyle modifications, with diet being the primary focus, supported by an increased physical activity. By empowering families with the knowledge and culturally relevant tools, we hope to promote early and sustainable health changes. We began our intervention by visiting Roosevelt Elementary School, where we conducted a needs assessment survey with parents. The goal of these surveys was to assess the specific needs of the community. And what we found was that many parents express uncertainty around what a healthy, balanced meal looks like for school-aged children, and further, how to determine appropriate portion sizes. The feedback helped us shape the focus of our intervention. So with this in mind, our main goal became clear: to empower parents with evidence-based knowledge so that they can confidently make healthy, informed nutritional choices for their children. We aimed to go beyond just giving advice. We wanted to make sure that parents felt confident identifying nutritious meals and serving proper portions that align with the child's age and developmental needs. And to implement this, we partnered with an existing program at Roosevelt Elementary School called Coffee with the Principal. During our session, we delivered a culturally sensitive and engaging presentation that introduced myplate.gov as a resource for balanced nutrition. And we also discussed recommended portion sizes tailored to different age groups. Ultimately, we wanted parents to walk away feeling empowered, not pressured, knowing that they already have many of the tools and ingredients at home to support their child's health. And this is just the team in action, talking and really having an open conversation with the parents of Roosevelt Elementary School.
Okay, now to cover health literacy, cultural humility, trauma-informed care, equity and inclusion, and advocacy. So when we first stepped into the Linwood community, we didn't come with a ready-made plan. We came with open ears and ready to learn. We listened to parents juggling multiple jobs, to teachers who were stretched thin, and to families doing their best with what they had. We heard about tight schedules, budget constraints. Many were only Spanish speaking, and each had a deep level to be healthier for their families. But many did not always have the tools or the time to get there. And that's where we started, not with assumption, but with real stories. We knew if we wanted to make a difference, we had to meet people where they were. So we showed up at Coffee with the Principal, which is an already established monthly meetings parents attend. We also partnered with trusted school staff, such as the community case manager, Juan Guevara, and the principal, Dr. Perez. We built this intervention and presentation with the community, not just for them. And it had to be accessible. So everything we created was bilingual, English and Spanish. This includes presenting our intervention, providing meal plans, and materials for the parents in both languages. Materials were culturally relevant, grounded in the real lives of Latino families in Linwood. We talked about familiar grocery stores near them, like El Superior, and shared simple, affordable meal ideas that honored cultural food traditions. Health literacy came alive with interactive My Plate visuals and hands-on activities that sparked conversations and connections. We made it fun. We made learning fun, practical, and real for the parents. We used trauma-informed principles as we created a safe, shame-free space, and we emphasized progress over perfection. We also, something simple that we included for trauma-informed care was introducing ourselves, who we were, and also using our USC name tags to help continue building the trust for grade school parents. Equity and inclusion is also seen as, again, we used Spanish, asked open-ended questions, and made space for families to share their stories and their truth. We didn't have all the answers all the time, but we made sure they knew their voices mattered. And finally, we planted the seed for advocacy. We shared local resources like food pantries, the community center, and CalFresh, and we made sure families knew where to turn to for support. We didn't just teach health, we helped families reclaim it together. And here are some visuals of the My Plate activity, the meal plans that we included in English and Spanish, and also visual representations to help families at home with portion sizes.
All right. So to measure the impact of our intervention, we conducted pre and post surveys amongst parents in both Spanish and English languages. These surveys helped us evaluate changes in knowledge, confidence, and understanding related to childhood nutrition and obesity among parents of Roosevelt Elementary. We focused on a few key ideas by asking parents to identify the major food groups, identify their level of confidence in building a balanced meal, demonstrate what a well-balanced meal looks like based on My Plate model. We also asked if they knew the health risks related to childhood obesity and if they could identify them based on the selection of diabetes, depression, heart conditions, or all of the above. And lastly, we asked if they could identify the factors that play a role in causing childhood obesity based on the selection of genetics, diet, physical activity, environment, finances, or all of the above. We had a total of 17 responses in the pre-survey and 18 in the post-survey. And although it was a small number of responses, we definitely saw improvements that we want to highlight. In selecting the major food groups, 82.4% of parents correctly selected grains, dairy, fruits, vegetables, and protein, which then increased to 94.4%, showing an improvement in knowledge of a balanced diet. When we asked parents how confident they felt with understanding what a well-balanced meal looks like for them, for their child, there was a significant shift. Initially, 0% felt very confident, but post-intervention,
38.9% reported feeling very confident, and another 16.7% felt confident, which means over half of our participants left the session feeling strongly or very confident in their knowledge. As for identifying the correct my plate, responses improved slightly with about 66.7% correctly selecting the appropriate plate after the intervention, up from 64.7%, which was a small but positive step forward. And when it came to knowledge of health risks, 82.4% of parents already knew the implication of childhood obesity going into the session, and that increased to 88.9% after the intervention, which shows we reinforced and built upon their existing awareness that they already had. And in identifying specific risks like diabetes, depression, and heart conditions, 64.7% of parents originally selected all of the above. And after the session, that number went up to 66.7%, again, reflecting greater understanding of how multifaceted obesity's impact can be. And finally, we asked about the causes of childhood obesity. Before the intervention, only 41.2% selected all of the above, which included genetics, diet, physical activity, environment, and finances. And after the session, that number jumped up to 72.2%, which showed a more holistic understanding of the issue, which was one of our key goals in conducting our intervention.
Okay, so for Star Wish, through our work, we realized that some of the most meaningful interventions happen outside of traditional healthcare settings. Educating children and their parents about nutrition in schools, supporting healthy habits at home, and encouraging active play in community spaces are all very powerful ways to influence lifelong health. And better yet, they are easily accessible. Change begins where children live, learn, and play. We learned that addressing childhood obesity isn't just about facts, it's about understanding. By involving families, honoring cultural values around food and health, and approaching the community with compassion, we built trust and made our message more relevant and sustainable. Empowering families through culturally sensitive strategies is the key to real progress. Our effort really was just the beginning. There's so much to be done here. With additional resources, we could scale our project, reach more children, and deepen our impact. The need is really real, and the enthusiasm from students and their families shows that this model does work. So expanding it could help bridge critical gaps in education, access, and equity.
So, as future healthcare providers, we're in a unique position to make lasting impact on childhood obesity, not just in the clinic, but in the community. Getting involved starts now. Volunteering with school health initiatives or local youth programs gives us real-world experience and shows kids that healthcare professionals care about their well-being beyond the exam room. We also need to promote healthy habits in our patient education, taking the time to talk about nutrition, physical activity, and lifestyle in a way that's relatable and realistic. And let's not underestimate the power of advocacy, whether it's educating families, mentoring peers, or supporting school policy changes, our voices matter. We have to be role models too, practicing what we preach and how we care for ourselves and our patients. Most importantly, let's lead with empathy. Meeting families where they are and being culturally aware in how we approach care will make us not only better clinicians, but better advocates for the communities we serve. Throughout this experience, we learned that education can be a powerful tool, especially when delivered with empathy and cultural awareness. Parents were engaged and asked thoughtful questions, which reminded us that most people want to do what's best for their kids. They just need the right information and support. We also saw how important it is to meet people where they are, not just physically, but emotionally and culturally. Communicating clearly without jargon and listening as much as we spoke made a huge difference in how our message was received. Ultimately, this project reminded us that our role goes far beyond diagnosing and treating. As future PAs, We have the opportunity and responsibility to educate, advocate, and connect with communities we serve. Childhood obesity isn't just about weight or BMI, it's about food access, habits, family stress, culture, and more. If we approach this issue with compassion and humility, even a short conversation can have a lasting impact. These early preventative efforts really do matter, and we have the tools to start those conversations now. Thank you so much for your time and attention today. We truly appreciate the opportunity to share a project that impacted us deeply. This experience reminds us why we chose this profession and how even small efforts can lead to meaningful change. We're excited to carry these lessons forward into our future practice.